We have our new assistant professor, Dr. Gabriel Robles, who is going to be sharing with us some of his work on HIV prevention, sexual minority men in the US. And so I will not take up any more of his time, but hand the mic over to him.
Hi, everyone. As Eric mentioned, my name is Gabriel Robles, and I'm assistant professor at this first method here at USC. So I first wanted to acknowledge the funder. This work was funded through the Study for AIDS Research, also known as CFAR. It was specifically a subcontract from the CFAR that was administered through MDC, CFAR. I also want to acknowledge the project team. Sorry, as well. So these are the people that whose help I very, very much value, and they're still collaborators to this day on this project and others. And so let's get started with the background. So as of 2012, the US FDA approved Truvada for use as a pre-exposure prophylactic for the prevention of HIV. So it was the first drug to be considered a pre-exposure prophylactic or a PrEP. It's important to note that PrEP or pre-exposure prophylaxis are used among other infectious diseases, but for the purpose of this, when I say PrEP, I'm actually saying PrEP for prevention of HIV. So specifically, we have an oral daily generic Truvada or Truvada. And we also have another name brand, which is an oral daily Descovy called Descovy. It's here using the formulation. But also over the course of the pandemic, an injectable PrEP got approved by the FDA, and so that is known as Apretude. And you can see here that our IRO 211 PrEP, which is not currently FDA approved, but it is to some degree used out in the field. In a couple of minutes, I'll talk about that. And so the CDC recommends PrEP as an HIV prevention strategy, mainly because it is highly efficacious. It is about 99% efficacious in reducing the risk of getting HIV among those who would acquire it through sexual contact, and it's HIV among persons who inject drugs by about 74%. And so here you can see that the use of PrEP coverage has been increasing steadily throughout the years. It's roughly 5 to 10% per year, which is great. And here we see that these are there are some of disparities starting to emerge, at least as it relates to age. You can see here that those that are aged 35 to 44 have greater PrEP coverage at about 60%. And it's important to know, when we're always talking about numbers, what the denominator is. The denominator here is those who would benefit from having if you're engaging in some type of sexual activity that is deemed high risk or injection drug use. But here we can then now see that there are some racial disparities. You can see the dark blue line at the top to red and green lines at the bottom. So if you focus here, you can see that among the white population, among those that could benefit, there's 94% coverage. So that's astounding. But if we look at the Latino and Black populations, we see that those rates are at 24 and 13%. So these are, what would be considered dire disparities. And so I would not be a social work researcher if I didn't take into account the social structural context that these men live in. So for example, the number one barrier to PrEP is the cost. Health insurance taxes, anything related to the provision of healthcare in the United States, which is driven by health insurance. And additionally, another thing that is contributing to the barriers is the misinformation. And so many people who could benefit from PrEP, who may be aware that they would benefit from PrEP, often are not seeking it because of some misinformation, namely that is kind of disseminated throughout social media platforms. And so I think in 2019 or 2020, there was this large, what we would consider anti-PrEP campaign over social media, in which there were a lot of ads targeting sexual minority men, with ads saying that Truvada is going to get, sued, and would you like to sign on to the lawsuit? And they would list specific side effects, and some of them are considered major or fatal. And so, even though these ad campaigns are no longer up, and a lot of the side effect information has been debunked, the damage is still done, and there's still kind of the word out there that maybe taking PrEP every day might not be the best thing for the body. And so for those of you that have followed the pandemic with regards to the vaccine, so similar misinformation was put out there, and so this was also happening in tandem with the COVID pandemic. And so another other barriers that are related to PrEP use is the appointment frequency. So if somebody generally wants an appointment, it's very rare that they can find a same day appointment. Sometimes it's rare, depending on what your context is, to find an appointment within that same week. And one of the things that is notable about PrEP is that often first-time users who are seeking PrEP probably had a recent exposure, and they are kind of in what we can consider crisis mode. And so when they reach out to a health clinic or a healthcare provider, they're told that, the next available appointment is in 2 weeks, 3 weeks, or a month, depending on which clinic you're at. But now that we have several modalities of PrEP, and some of which require a daily pill, others require an injection that is taken every other month. But then if you take into account how many appointments one would need, or basically for the duration of treatment, it creates a barrier, knowing that they're going to have to come back for an appointment, either every 3 months or every 2 months, depending on which type of prescription, which type of PrEP they're prescribed. An additional barrier that is specific to Latino sexual minority men, those that are Spanish dominant, is the linguistic abilities of the clinic personnel. And so one of the things that we've been hearing out in the field is that there seems to be kind of this stratification of these two groups of Spanish speakers of people in the clinic. So one is the staff, and then the other one are the healthcare providers. And so the patients overwhelmingly say that, yes, the staff can speak Spanish. There's often, a receptionist or someone in the office that can speak Spanish. But usually when they go into the healthcare room or to the exam room, the provider does not speak English, and they're relying on either a hotline or an interpreter of some type. And one other thing that they have noticed with regards to those that are categorized as staff is that a lot of the times when you are a Spanish dominant Latino man trying to seek PrEP services, usually then you get routed to a PrEP navigator, which is kind of a community health worker who then helps you through the system. Through that is where patients are reporting that they often do get made aware of PrEP. They often get referred to a specific clinic, and all of that is done through usually a social support system. Usually it's a peer that says, this is where I got the PrEP. Maybe you could also go there and talk to so and so who could speak Spanish. That type. And so the present study, the aim was to examine the preferred attributes of the various PrEP types, which include the administration method, the dosing schedule, the clinic factors, And we employ a quantitative survey that's embedded with the discrete choice experiment. During the method section, I'll talk about what a discrete choice experiment is. So this study was part of a larger mixed method study examining queer men's health, specifically as it relates to PrEP uptake. It was a two-phase study. The first phase, we spoke to providers that worked at a PrEP clinic, and then the second phase was a quantitative survey in which participants or potential patients would take a survey. Recruitment took place between April and August of 2023 via dating apps and social media. To be a part of this study, you needed to be 18 years or older. You need to live in the United States, and you needed to identify as male, and you can read English or Spanish. And so the largest sample was 1,009 men. But for this specific study, we looked at people who were HIV negative, because if you were HIV negative, you were then routed to the DCE component of the survey. The study procedures were approved by the IRB of University. And one thing that I forgot to put up here is that participants were reimbursed using a raffle. There were 10 winners, and you would win denominations of $200, $100, or $50. And interestingly, because this was done in the state of New Jersey, and gambling is a big thing in New Jersey, I needed to register with the New Jersey Office of Gambling because I was promoting a raffle. And so basically, I just needed to state that distribution purposes, there's no buy-in, and then I had to provide proof of IRB. So with regard to the measurement, we collected demographic data. As you can see here, age, racial identity, sexual and gender identity, relationship status, education, and of course, health insurance. But we also collected information on PrEP prescription history. So the original variable is 3 levels. Yes, I currently have a PrEP prescription. I don't currently have one, but I had one in the past, or I've never had one. But we then collapsed the variable into dichotomous. You previously had a PrEP prescription, or you never had one. And so now onto the DCE measurement. And so basically what the DCE does, it provides kind of the scenario of possible options that a person can take when they're going to select a PrEP. I'll show you an example. I think it's in the next slide. And so basically we described, for example, scenario 1. For the route of administration, maybe it's a daily pill. So do you think you would like a daily pill that has low side effects, that, you know, your friend referred you from a provider who can speak Spanish, for example? And then there was another example below that with a different configuration. And then the participants needed to select which option was the best. And so we measured, we presented a route of administration, which is it was either a daily pill, an on-demand pill, and an implant and an injection. So on-demand is a 2-in-1, and as I mentioned, I'll talk about it a little later. And the implant, we included the implant because the literature shows that it's very close to being FDA approved. So just to get kind of, you know, to prepare ourselves for the possible rollout of an implant, we included implant as an option. And then within the profile, we listed various side effects. And the side effects included the 3 most common ones, which is diarrhea, headache, or nausea. And then we also included information related to if you know somebody that has this specific PrEP, or if the provider can speak the same language as you can. And so here on the right, you can see what the example DCE would look like. So for example, as you can see here in option A, the regimen of 4 pills in which you have sex, but only when you have sex, and you'll have a medical appointment every 3 months. The side effect you may experience is diarrhea. Someone you know takes this kind of PrEP, and the health provider can't speak the same language as you do. And the other option is, for example, a once daily pill with a medical appointment every 3 months, A side effect you may experience is headache. You don't know somebody that takes this, and your healthcare provider only speaks Spanish. And so, of these two options, which option would you prefer? And you can see here they'll select option A and option B. So, based on the number of attributes, um, we presented 9 profiles, and each of the options were randomized. So, um, if one person took this specific survey, for example, option A and option B here specifically, they may not, another person may not be presented with this exact scenario. There's a combination of 9 total. And so after they took the DCE, then they were asked a question. We just wanted to assess the extent to which each attribute influenced their selection. So we asked them, does the importance of the medication type influence what options you selected throughout the DCE? Or the value of knowing somebody on the same prep, did that influence the various options that you selected in the DCE? And the same thing with potential side effects and the language of the provider. So each item ranged from 1 to 5. 1 strongly disagree and 5 strongly agree. And so for the analysis, we ran bivariate descriptive analysis for the survey participants. For the DCE, we ran a conditional logic model in which it was used to test differences in attribute levels based on the participant choice. And so it's important to know that although it looks kind of like an odds ratio, there is the outcome specifically is the attribute itself. So for example, here, attribute A has X number of higher odds of being preferred compared to the reference attribute B. And so when we look at the table, you'll see that it looks like an odd ratio table. But again, it's within each category. And so here are the demographics. I just want to point you to, that the sample was about 50% white. It was those who indicated that there were cis men was 90%. There were 72% gay. Most of them were single, and the vast majority of the participants had a post-secondary education of some type. And so, for those of you that are looking at this table, and you're thinking like, "Oh, I thought he said that this study was for male-identified participants or male-identified sexual minority men," and it was with the gender identity variable. We allowed participants to select which gender best describes them, and so some people selected multiple, and we presented here of those who selected man only. And so for the demographics, we see that most of the sample has health insurance, which, is interesting given that, up front, we know that a barrier to PrEP, the largest barrier is health insurance. And most people never had a PrEP prescription. The average age was 41, which is, kind of middle age for a typical HIV study, at least. The trend is that when people are conducting HIV studies, it tends to be kind of 18 to 29. Sometimes it's a little younger in adolescents, but like this middle age just before,
I can hear you very well. Can you say something again? Hello. I can hear it. Turn up your volume. Naomi, I'm so sorry.
Go ahead. Okay. I thought they were talking to me. Now I said and so a population of interest is that kind of middle level adulthood just before older adulthood. And so when we're looking at the follow-up questions about which attribute most influence your decisions in the DCE, we can see here that side effects was rated the highest, but closely behind was route of administration and provider that speaks the same language. And knowing someone that takes that same prep was not as high as the others. And so with regard to the DCE results, so as a reminder, so when we're looking at kind of the odds ratios here, we're comparing it to those to the referent within the same category. So for example, if we look at those that are significant, if you just kind of focus your attention on these red cells, you can see that on-demand had greater odds of being selected than a daily pill. Now, when we rotated the reference group, we saw that injection was had greater odds of being selected than the implant, but that was only significant at a 0.04999. So we have to be cautious about that given the sample size. And so when we're looking at side effects, you can see here that these two are red, and the odds ratios are reduced, which means that the side effects for diarrhea is in some ways people would prefer or more likely to select diarrhea as a possible side effect that they're willing to experience above and beyond headache and nausea. And so the categories of knowing someone who takes this prep and provider speaks the same language was not statistically significant. And so as kind of a summary of the results, participants preferred on-demand prep over daily regimens, and the concerns about side effects like headaches and nausea being significant barriers to prep uptake. So let's discuss some points. So on-demand prep is favored for its flexibility and lower adherence burden. And this is especially true for those who have infrequent sexual activity or those who can plan their sexual activity. So on the right, you can see kind of the protocol for an on-demand prep protocol. It's technically not a prescription because providers don't prescribe 2-in-1. They do it off-label. And so in the next slide, we'll kind of look at it closely. And so what it means is that fewer pills means that there's less cost concerns, there's less side effects, and you have the ability to conceal the prep. And these are often preferred, and the research kind of supports that these are some of the attributes that are preferred throughout the United States and the world. And one other thing is that on-demand appeals to those seeking convenience of their healthcare routine. So if you think about someone who is, as average age of 41, who is otherwise generally healthy, not having to take a pill every day seems kind of desirable. And so if it means to take pills on and around your sexual event, then maybe they're willing to do so. So just so that we know what 2-in-1 or on-demand is, as you can see here, down here where there's a little two, people, that's the sex event. And so so patients are instructed to take 2 pills at least 2 hours before, up to 24 hours before the sexual event. And then they're asked to take a pill about 24 hours after that sexual event, and then they'll take another pill 24 hours or 48 after the sexual event. And so this is in sum what a 2-in-1 regimen looks like. And so one of the things that we know from PrEP, adherence and just PrEP research generally is that it somewhat mimics that of HIV treatment research. And so the research shows that long-acting antiretrovirals are highly preferred among HIV people living with HIV because it reduces the burden of pills. It reduces pill fatigue, which is one of the most common concerns of those living with HIV, knowing that they have to take a pill or 2 pills, sometimes 3, every day for the rest of their life. So that can be daunting. And so some studies suggest that long-acting injectables, even within the context of PrEP, is more broadly favored than others because it removes the need for daily adherence. And so basically you get an injection every other month and you're protected. and you don't have to worry about taking a pill every day. And so research generally demonstrates that there's high user satisfaction and there's preference of an injection over an oral regimen. And so some concerns about side effects. So as noted, participants were more concerned about nausea and headaches than diarrhea. And diarrhea is the most common side effect of PrEP. And despite the greater concern for nausea and headache, some research shows that nausea and headache may feel, or the subjective experience of nausea and headache can impact, the cognitive function. So if you think about, you're walking around, going to work, going to school and whatnot with a slight headache or a little bit nauseous, I'm not sure if you've ever felt those symptoms, but they can be very detrimental. And in some ways, when you think about kind of diarrhea, which we know that, in some people, diarrhea may interfere with their sexual health goals, especially if you're engaging in anonymous anal sex. But users did prioritize diarrhea over the other side effects. And so some implications are increasing awareness and the flexibility of PrEP options like on-demand and long-acting injectables, because we know that those the patients prefer those. And healthcare providers need to have more training on what 2-in-1 or the 2-in-1 regimen is, despite it not being FDA approved. Now, if you kind of take a look at who is being recommended a 2-in-1 regimen, it would be someone who goes to a particular clinic, who has a particular provider, who has been trained and has kind of bought into the idea that maybe, not every patient needs a pill every day, and something that's a little more episodic or on demand might, suffice. And so unless you're going to a provider that, understands and, believes in the mission of the on-demand PrEP, you're likely not to be recommended or even be informed that 2-in-1 is a thing. And so that kind of, feeds into the idea, or not feeds, and it kind of influences the idea that some, maybe there might be some, racial, disparity, or people who go to specific providers with the most knowledge about PrEP might be from a particular demographic. And so public health campaigns should promote the convenience and reduce side effects of flexible PrEP options and to increase PrEP uptake among target populations. Because we know that, some options are preferred over others. And so some of these public health campaigns should highlight those, should inform the masses that there are multiple PrEP options and maybe injectable PrEP or on demand, though I don't know what would be like the legal implications of, advertising a non-FDA approved method. And also kind of highlight this idea that these specific PrEP regimens don't have the extreme side effects that, these social media campaigns promoted. And those are very rare. They are technically in the literature as very rare. And so people just kind of took that to mean that, if you are experiencing these side effects, please contact us, which is what the ads were looking at. And so some of the limitations are that the sample was recruited from specific sources, limiting generalizability. So those who are, app users, those who are on social media, those may not be the people that are most at need or in most need of PrEP services. And so based on the demographics, we see that the sample was predominantly white, educated, insured, middle-aged, which potentially skewed the findings. And so on-demand PrEP is not FDA approved, and so it raises concerns about its financial feasibility and insurance coverage. And so while social support literature suggests that PrEP referrals are shown to be positive associations with PrEP utilization services, the study here did not find that that peer support or peer referrals were were significant. So future research is needed. And future research is also needed to explore the effectiveness of on-demand across diverse populations, especially in managing missed doses. And so for final thoughts, PrEP preferences may vary, with many favoring on-demand and some preferring long-acting injectables. But limited availability calls for better provider education and stronger policy to support expanded access. And we need to make sure that we're aligning public health efforts with these preferences so that we can enhance HIV prevention and promote equity or equal access to PrEP services. Thank you.
Got a few minutes for questions. Does any maybe want to say into the mic, ask if there's any
So
questions?
do you have any questions? Does anybody? Feel free to jump in. Can't see a chat.
Well, I'll ask a quick question.
Oh, yes.
You may have to just repeat it briefly. So this is really interesting. Thank you. I thought the findings about sort of side effects and being something that people were concerned about and the convenience were really interesting. You had mentioned that it's a relatively large for this kind of study, at least sample. Did you look into any race or ethnic differences in terms of how people responded to those preference questions?
Yeah, we did, but because the racial the vast majority of the people were identified as white, when we looked at kind of stratified model, some of the confidence were really large, and so we just thought that it wasn't the best to present that type of information. But we did stratify the model between those who had previously a PrEP prescription and those who never had a PrEP prescription, and the results were almost identical.
Okay. But you didn't have, so basically you just don't have the sample size to look to see if Latino or African American men,
Right.
At the beginning of the presentation, you're really talking about a concern about those groups in particular because of the high uptake of PrEP with, white, middle-aged men relative to everybody else.
Right,
And
yeah.
so if that's most of your sample, I wonder if you've been thinking at all about are these preferences the preferences of the people who are already on PrEP, or are these preferences of the people who need to be on PrEP?
Oh, right. And so here we everybody here is not on PrEP.
Mm-hmm.
And so basically, if we generalize, of course, that's limited. It's kind of white, middle-aged, educated guys who are app users who are not on PrEP. These are their preferences.
Okay.
So at the beginning, another thing that you point out is that there's a differences by age, and the mean of age was 41. So probably there is some sort of distribution, and I was wondering about whether or not you look at that kind of age, the variation, whether or not age play out anything, like in terms of their preferences and a whole kind of thing. I was curious about
Oh
that.
no, so we haven't. So first thing, this analysis was done like weeks ago, and so
Nice.
we're in the middle of finishing the first draft of the manuscript. So that's what the point of this was, right?
That's great.
And so yeah, but that is a good idea because we see that the middle-aged folks are more likely to have a PrEP prescription
Yeah.
relative to particularly among the younger folks. Yeah.
Right? And especially like younger ones and a sexual activity and whole thing, like age, the age might be really important factor. And if I like targeting that age group, we want to have like a set of a specific preference. If their preferences are totally different from the other age group, then I would think that it is really important factor.
Right. Yeah. And one of the things that we talk about with my community collaborators are that generally those that are kind of in that middle age, 35 to 45, I forgot what the the distribution was, those are the people that have jobs that provide healthcare insurance. Those are the people that, some ways are already connected to the healthcare system. So going for a prep visit might not be out of the ordinary. Those that are younger might have part-time jobs with no, benefits, or are still on their parents' insurance and are reluctant to use that to access prep. And so another thing that's kind of contributing to some of the disparities is that depending on which city or which county you live in, there might be some prep services that are offered for free or that are subsidized by, some type of program. And so, but generally you have to live within those geographical locations to be eligible for those services. And one of the community partner that I work with this study is in Washington, D.C., and they have some type of program to subsidize the prep costs, but you have to meet certain criteria.
Mm-hmm.
And so if you live kind of in the suburbs or outside of the district, then maybe you're not eligible.
I'm not walking away. I'm getting to see what the chat says. So looks like you've got 2 questions online. One is, you can see them now. Yeah. One is your limitation number 2, 50% educated white and insured can speak to the population, not addressing potential issues, which I guess is sort of what you were just discussing. Do you want to add anything else to that first comment? Because you were addressing some of this just a moment ago with Olivia's question.
Yeah, I think so. So I don't have anything, but the other ones, in what ways are could information contribute to general medical education? And so one of the interesting things that in medical education, I am to some degree familiar with how medical education is run here in the United States, and how residencies are. There tends to be, depending on which hospital you're conducting your residency at, you may or may not, have that much exposure to kind of the HIV, realm of healthcare. Some hospitals have a specific HIV-related track or a fellowship or a certificate program, and those generally draw a particular type of person who may already be interested in this and may already kind of know, what is happening. But one of the things that I had been talking to with some residents at the Yale primary care program is that there really wasn't that much information unless you did some type of clinical rotation at the HIV clinic.
Mm-hmm.
And so then they would rely on kind of seminars like this, in which somebody would come in and present information. And so the one thing that she kind of told me was that there was zero mention on other populations that are not, gay men. And so we know that HIV, infections are rapidly increasing among Black women. And so we just started talking about what are ways in which we can kind of integrate that into the broader residency program, and not necessarily, only those that are in some type of track. And so, yeah, I do think that there should be some type of education requirement that goes above and beyond a weekly seminar when somebody comes in for a couple of hours to talk about prep. Then that's kind of the extent to which they get the information.
I think we have time for maybe one more question. Is there any more questions online or in the room? Well, then I'll ask one last question. So what's next? Where do you want to take this next?
What is next is, so I, maybe a month ago or 2 months ago, I was awarded an R21 among sexual minority migrant men. And so we are integrating some of these attributes or some of these characteristics within that, so that we can then, help design, recruitment methods, not recruitment methods specifically, but how we can refer people into healthcare services, given that they come to the United States, they're brand new. Of course, they do need legal services, but that doesn't mean that they, shouldn't be offered the opportunity to seek healthcare services as it relates to PrEP, especially for sexual minorities.
That's great. That's great. It looks like you had one last comment here, which was Vienna Star provides PrEP services under a grant program primarily for Latinx. Oh, so just sharing about community resources.
Thank you, Mike.
That's great. Well, let me just thank you all for showing up again this week. Let's give a round of applause to Gabriel one more time.